In this brief module, I will introduce the topic of applied medical anthropology. Generally speaking, applied medical anthropology is an orientation in medical anthropology that analyzes the socioeconomic forces and power differentials, as well as other cultural forces that influence disease patterns and access to care, and then deals with medical intervention, disease prevention, and related policy issues. Applied medical anthropology attempts to make a difference in medical care provided to people through the proposal of and/or implementation of healthcare practices and policies with a consideration of people's culture. Thus, like all medical anthropology, applied medical anthropological research begins with and is reliant on 1. Understanding where one's research question or problem being solved fits into what we already know about how culture influences how people fall ill and receive treatment, i.e. theory. And 2, collecting first-hand data through ethnographic research. These first-hand data that are collected, of course, specifically relate to a particular people's beliefs and behavioral patterns that have an effect on the way that diseases spread and have an effect on the way that people seek treatment. Once this data is analyzed and placed in relation to the theory, the applied medical anthropologist will either propose recommendations or, if in a position that allows it, institute policy changes that can ameliorate the medical-related issues that people are facing. Described in this way, applied medical anthropology constitutes a subfield of interest for applied anthropologists, just as much as it forms an orientation within the field of medical anthropology. Applied anthropology, or what is often referred to as practicing anthropology, for its part, is the use of anthropological theory and methods to serve real-world purposes. In other words, meet the needs of people. In practice, this amounts to simply conducting anthropological research as any anthropologist does. The difference being the purpose or intent behind the research. In the case of applied anthropology, the intent is for the research to have an ameliorative impact on people, to solve what are perceived as people's ails in society, for example, poverty, inequality, etc. But more specifically, in the case of applied medical anthropology, decreasing the spread of disease and increasing access to health care. Applied medical anthropology has had a significant impact on how we deal with illness today. Among the earliest anthropologists to specialize in medical anthropology, with a focus on applied research, were Margaret Clark, George Foster, and Purdy, aka Bert, Pelto. From her first book, Health in Mexican-American Culture, to her later works such as Culture and Aging, an anthropological study of older adults, Margaret Clark was among the first to emphasize the importance of understanding and attending to the role of diversity in the study of health and disease, the practice of medicine, and the training of medical and nursing clinicians and other healthcare providers. The term diversity not only included socioeconomic, ethnic, gender, and age differences, but also considered the effects of migration, disability, and sexual orientation. She also extended the principle of diversity in practice to include the effects of technological innovation on health and well-being, and was among the first to study the social and cultural consequences of HIV/AIDS. In Culture and Aging, Clark presents suggestions for medical professionals and policymakers about the aging population. As a result of her expertise in the area, she served on the National Advisory Committee for the 1981 White House Conference on Aging, and as a consultant to the National Institute on Mental Health and the National Institute on Aging on many occasions and topics. George Foster, for his part, was a medical anthropologist with interests in public health. Foster made significant contributions to understanding how and why modern Western medical systems are accepted or rejected by developing countries. He also made great strides towards understanding how medical beliefs and practices are transmitted among populations, and the impact of medical bureaucracies on people who receive medical care. He was a consultant to the World Health Organization, the U.S. Agency for International Development, UNICEF, and many other medical agencies. He traveled widely on these agencies' behalf throughout Asia, Africa, and Latin America. Bert Pelto, on the other hand, played a major role in developing the earliest program in applied medical anthropology at the University of Connecticut. He began an association with the University Medical School's Department of Community Medicine and helped to establish the Hispanic Health Council with Jean and Steve Schenzel. The Hispanic Health Council was and continues to be an NGO that works towards improving the health of Latinos in Hartford, and it has spurred a number of anthropological projects to engage in this type of action research. Pelto has also served as a consultant for many international health organizations, providing training in mixed methods ethnographic research for community-based applied projects. In general, there are two separate but related motives for applied medical anthropologists. One is exposing social and cultural issues that affect disease and treatment patterns, studying up and examining policies that can help suppress disease spread and improve treatment or access to treatment, advocating for the affected group, and making recommendations for prevention and intervention. Another is the implementation of that anthropological knowledge by designing policies, programs, and activities, and initiating projects that will have the desired effects of helping to suppress the spread of diseases and improve treatment and access to treatment. The latter motive is generally initiated from within NGOs or from within a governmental or international agency dedicated, at least in part, to healthcare, such as the World Health Organization. The difference between basic or pure medical anthropology and applied medical anthropology is that applied medical anthropologists deliberately become advocates for the community and attempt to do research that is useful and ethical. Theories on how culture affects behavior related to health and the methods that anthropologists use to collect data to form those theories can be applied in many different contexts. Anthropologists, for example, work in clinics serving multicultural populations, in maternal and child health programs, on surveys of community responses to environmental hazards, on program planning and evaluation in psychiatric hospitals, on AIDS prevention programs, and on the reintegration of people with traumatic brain injury to community life. The populations served are often people on the margins of mainstream society: refugees, native peoples, rural elderly, drug addicts, people with disabilities, and ethnic minorities. As an example, the research I conducted in Belize with the Maya Mountains Ethnobotany and Ecology Project, or MEEP, had the ultimate purpose of addressing the healthcare needs of the Kekchi Maya in southern Belize. The Kekchi, in this case, comprised the host community. They were responsible for creating Itzama, the medicinal garden discussed in the Rojas et al. Article, and it is they who permitted us to help them improve Itzama through our research so that plants could be more readily accessed for treatments. Today, the Kekchi Maya are an ethnic minority in Belize. According to the 2010 census, they made up 5.7% of the population. This stands in stark contrast to the two largest groups in the country, namely the Mestizo population at nearly 50% and the Creole population at nearly 22%. The fact that the Kekchi live in the more rural part of the country has put them at a disadvantage when it comes to obtaining easy access to health care. Thus, the importance of having a local center of healing is of paramount importance to the Kekchi for treating certain illnesses. To conclude, the practical aspect of applied medical anthropological research must not be neglected, and therefore I will briefly discuss this aspect, which often gets overlooked, but which is necessary if any changes are to be made that can benefit the host community in terms of disease prevention and treatment. Like any applied anthropological endeavor, as an applied medical anthropologist, there usually are several stakeholders or interested parties affected by the research conducted by the applied medical anthropologist. These stakeholders or interested parties include first and foremost the host community ultimately affected by our research. And second, our employers and other sponsors who we owe accurate reporting of timely performance of the research we undertake for them. These stakeholders, of course, may be one and the same. Other interested parties might include our professional peers or colleagues who we represent, and our employees or students who may be helping with the applied medical anthropological project. Often, too, we must cooperate with organizations led and operated by members of the host community, as well as the government of the country within which we are working. My own applied research, already recounted in the first module, mainly involved the host community, namely the Kekchi Maya villages of southern Belize. But it also involved cooperating with the Kekchi Maya Healers Association, an organization which in turn is a branch of the Belize Indigenous Training Institute. The sponsor for this research, for my part, came from the university with which my colleague, with whom I worked on this project, was affiliated. This can lead to a complex web of negotiating with the various parties involved to reach a solution that is ultimately beneficial for the host community, but which of course addresses the concerns of all parties involved.